Today, we will cover two cancers that has always been a bit of an enigma for the team when it comes to in terms of how to deal with it. I didn't want to go too long, and we'll try to keep it within an hour 15 minutes. The reason is because the last session I thought it was a bit too long. It gets a bit hard, while at the same time I'm being pulled at least by 3 other places, so I would need to rush a bit. Everybody can see, right? Can y'all see this video?
Yes, can see.
Okay, so for those, we'll start off by looking through. This is essentially what we mean by bladder cancer. Okay, this is a patient that I just did a few days ago. Okay, as you can see, I'm not sure even Hong Kong might have seen it at all. So essentially, as y'all can, okay, wait, this is a good view. So as y'all can see, this is the bladder. This is how your bladder looks like inside for those of you who have never been inside the bladder. And the bladder is actually a big bag that we store our urine. The normal capacity of a bladder is around 300 to 400 mils of urine before you need to go to the toilet. That gives you around, and if let's say we produce about 1 mil per kg per hour of our body weight, 1 to 0.5 mils. So let's say it's a person who's around 60 kg, you end up producing around 30 mils of urine in an hour. That's the minimum. If you drink more, which you're supposed to around hit 60, 70, and essentially what you're looking at is you're probably going to toilet every 270 or 250 mils. Your bladder starts getting a bit full. You are asked to go to the toilet, and essentially that's why people usually go to the toilet around 3 hours. So for those of us who are either holding on your urine way too long, like 4 to 5 hours, or you're going to the toilet every hourly, you need to have a private conversation with me lah. But this is how a bladder looks like. I wanted to show you how the inside of a bladder looks like. If you see this screenshot that you have, on the left hand side, you see this this part of the left hand side screen. This is, oh, okay, wait, this is even better. This is actually a fairly normal view of how the bladder looks like. The top 2/3 of it is how a bladder looks like. The bottom 1/3, you all can see that little broccoli-like structure at the bottom. Okay, and essentially, if I play a bit more, this gentleman has very bad disease, and all those very nice little actually they look quite nice. They are called papillary lesion. I'm going to play that back again. As you can see, the papillary region is right at the bladder neck. Once I go into the bladder, it's like opening a curtain to Jurassic Park like that. You see all these things, all this abnormal growth. This part on the top hand side is a bit normal, but even then you see a little dot down there, and as I look left and I look right, I see more and more cauliflowers coming into picture, and this is a fairly serious case of bladder cancer. Now, only with that, I thought then we can fully understand why we do certain things when we come to talk about bladder cancer today. So normally, traditionally, right, they usually come to us with a certain symptoms. The symptoms that they usually come to us is essentially, I got blood, doctor, I got blood in the urine. How come I every time got infection and things like that? As you can imagine, they start bleeding, and as the urine comes out all red color. And essentially, that's one of the common reasons why when the people come to me for bladder cancers. Bladder cancers, as you look into it, they are not, unlike other cancers, when we talk about cancers, right, there are always a few oncological principles. The principle is R0 resection and R1 resection. R1 resection and R stands for R resection means it simply means complete resection. Meaning to say I took everything one out, left some behind. So when it comes about oncological cancers, right, unlike every other cancers that we're talking about, say the kidney with a cancer here, or we have a prostate with some cancers here, we tend to aim to take everything out, which is what we call R0. And we took this out, it's called R0 resection. But we're coming back to the bladder. As you can see, I cannot take out the bladder like that. Because once I take out the bladder, you do got nothing to store the urine. And I already mentioned to you that they normally take around 30 mils of urine per hour. If I don't have somewhere to store, literally a person then need to stand in the toilet and for continuously have some drips and drops of urine coming to the bladder. So the bladder is not something I can chop up and do an arm knot resection like that. Okay, so we go down to bladder cancer management, a bit more details. Assuming this is my crappy drawing and essentially this is the bladder, all right? The bladder has many layers. I'm going to use this color. This is one layer and another color will be another layer on the other side. A bladder essentially is a muscular structure. You can think about it like them being inside, this is the urine that stays inside, okay? A bladder is a huge muscle and muscle has very many different layers. When we have a bladder lesion that grows out, just now like you see in the video, right? Unlike other cancers, I told you, I cannot take away the bladder in its entirety and take it out and say, oh, you're cured, because people need. So what we do is that we tend to try to scoop the bladder out and dig a bit of the underlying cancers away. So much so that what you have is end up having a situation like, what you have is essentially you take away this one, you cover like that, and you scoop it up so that it becomes like that, as a whole. All right, that's a whole. Okay. Because some cancers are also very big. I told you like that, right? And it grows into like that. My instruments, which you can see my camera is really like that. My knife, you can imagine, is maybe like that. There is no way, if I want to keep the bladder intact and make you have a bladder at the end of the operation, I can take everything up in one piece. So what do? We chop like that, 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 we chop like that. Now, then after that becomes many pieces, we flush them out. Now then you understand why in some sort of histological things that you go through, you would never see the traditional description like a 3 by 2 by 1 centimeter lesion or whatever lesion is a solid block lesion. Because for some cancers, this one is kind of like an arm knot resection. But I told you, this one piece, it's quite useless to give you a measurement, because this probably will be a 3 mm by 3 mm by maybe 2.5 mm, and then there will be thousands and thousands of pieces. And there's no way then to give you the biggest piece, because they could give you this piece or they could give this piece, whichever piece they want to choose. But the key and the unique point about bladder cancers is we don't really care how big this lesion is. What bladder cancers, the unique point about bladder cancers is actually the various depths that we talked about, which is essentially the layers. Okay, if we were to talk about the layers that we said just now, and I zoom into one of them, let's zoom in. Imagine this is the one layer and another layer and another layer of cancer. We got this lesion down there, right? There are different layers, and the layers we found is, sorry, Fiona is being locked out. She's asking me to Amit, sorry. Okay. All right. So going back to this, Fiona, can you hear me? If you can, just say something and type something. Say something, because I cannot share the screen. Sharing the screen. So, Fiona, are you in? Yeah, Fiona, I think Fiona can see now. So I'm just trying to make sure Fiona can see because she's critical. Can you hear us, Fiona, or see us? If you can, make a sound, something like that.
Yeah, I can see the screen.
Okay. So you were to zoom in like that, and we're talking about it. We're just talking about the bladder. I'm not sure whether you've gotten, but I recorded it, and we can go back again. So if you see the cancer like that, right, it's really not a matter of how big or how small the cancer is. The unique key about this is actually the depth of invasion that matters. We all learn that sometimes a big fat tumor like this, it can be very, very big. Let's say 2 centimeter by 2 centimeter by 7 centimeter long. We have to chop it off. We have to take everything out as best as we can. But really, we don't really care about that. There are two reasons why there are two goals every time we go into a bladder cancer, like we said just now. One is to chop off all the nice little form that we see. That's number one. And the second, more important one, but very, very, very unlikely that you appreciate it from the histology report, is to actually get a depth of invasion. One is really just to stop the bleeding, which is a symptom. Two, however, is actually staging a cancer. Because there is difference between a cancer that is this and the cancer that is at this level. Why? There are some cancers, these cancers, I said to you, the muscle level is very vascularized, means there's a lot of blood vessels. A cancer that is in the stage A, if you have not hit the muscle level, okay, we call this laminar propria level. If you actually did not hit, in terms of A, you only hit the laminar propria. Our experience with dealing with bladder cancer, we know that once you scoop it out, and if let's say the tree is taken out, the roots are not so deep, you only reach the laminar propria, and once I remove all the roots, the outcome is very good. Okay, but we know that if you hit B, the tree trunk may be big, but if you hit the depth, which is the muscle level, the prognosis, which means what you're likely to occur, is going to be bad. It's like a no-go zone that the bladder cancer cannot reach, which I'm desperately trying to find out every time I go to an operation to try to remove the bladder cancer. A is good. B, very bad. Because A, once I carve it up, end of story, that's it, done. And every time I come back and look, I get to keep your bladder. B is no good. As long as you have a bit of a B, muscle layer invasion, we know it's not good. The whole bladder is going to come out. And we talk about whole bladder now, it's not a simple thing. We talk about then having to create a new bladder out of nowhere. Or I put it into a stoma. You all seen stoma before? This is a diagrammatic drawing of umbilicus in a person with the stomach. And stoma is essentially a bag where all the urine comes out here. It can be poo, it can be urine, depending on what you have. It can be poo, which is green color, or it can be urine, which is yellow color, depending on whatever cancers you have. So a stoma, you can imagine the patient actually it's a fair bit of a change to him. It's not something I do lightly. And by the way, to take out a bladder to reconstruct, it takes about 8 to 9 hours worth of job. If we're just doing a conduit, it's still a lot. We're talking about 5 hours job. And an operation that's 5 hours for anybody is a fairly big thing. So as you can see, why it's important to differentiate A versus B. And even if the person has many times of A, now as long as he is not as bad as as long as it's actually something along the line that is small enough for me to handle, even if it's like that, I would rather come back many times. I chop it off, end of story. I chop it off, end of story, and we can do it. It's okay. I keep the bladder for you, and keeping the bladder is important for everybody, not just me. If it's not, as long as it's not like that, then it's a good thing. So that's why when you encounter histology, you will see first, that explains already first thing why you get the kind of the dimensions that you have. Many dimensions. And you have no idea why. While in prostate cancer, you see one dimension. You see kidney cancer at one dimension. Any other cancers that you will see is usually one dimension because we try to do a R0 resection. But as I explained to you, for bladder cancers, we cannot do a R0 resection because of technical challenge, i.e. my instrument is only so small. And number two, it's not something that I do lightly because it's a big operation. Okay? So now I hope you understand the kind of the report that you read. The numbers that you read here is important, but they are not the key. If you go back and read all the histological report, the other thing is the staging. T staging, T1, T2 and everything. And the difference between is laminar, superficial, laminar, propria, muscle. That's the one that is really key. Key staging, as you'll probably get an idea now when you look at all the various histological reports, is that the bigger the number, the worse it is. And it's the same with every cancer. And it's the same thing here. The bigger the number, the worse prognosis it is. All right, T4 being the maximum number, there's no T5. So T4 is the maximum number, just the number of airport terminal we have, no T5. Please at least know that when people ask you, you say in medical domain, you must at least have some knowledge. And the bigger the number, the worse it is. And when we talk about the histological reports, very many times we talk about that. We talk about that. We talk about that. We talk about that. We don't really, it's not key here. Because it doesn't tell me much. I said to you, the reason why I got so many, because I have to chop it out like that. Giving you this bigger piece or this biggest piece is not important. What is important is the stuff here. How deep it is. Not how many pieces, how big the pieces. In other tumor, it is important. In this tumor, not so important. So at this point of time, anybody got any questions? Because this is a very important concept and this explains a lot of things. And you can imagine, and I hope that it clears out a lot of conceptions that you may have as it. How come in other cancers, the size matters? We look at the size, but in bladder cancer, the T1 and 2 is looking at the depth. Is not a dimension-based classification. Any questions so far? Yes, no, quick. Feel free to ask. There's no stupid questions. And if you all don't understand, also feel free to clarify. Like I said yesterday, 2 days ago, I listened to the organization and I didn't understand half before that. But after the lecture, I understand 25% more. That's all. But every time we will go through this over and over again. Anybody got any questions? Burning questions, especially the team that needs to deal with histology of the bladder cancer. So I hope they clarifies a few things. For bladder cancer, maybe now that you understand a bit more, the algorithm and the way we treat it and the approach and the rule that we set for the rule-based approach cannot be as per business as usual as for other cancers. And in the realm of oncology, you will always face things like this. Today is bladder cancer, tomorrow is lymphoma. Lymphoma is even worse. Lymphoma is a blood-borne blood cancer. In lymphoma, you can imagine there will not be a solid thing that we talk about. Yet there is still TMM stages for everything, but we figure out other TMM way of classification. We will find out there will be always ways. So Hong Kong has that little big direction, that dictionary book AJCC. Imagine council upon council of old men sit together, wise men sit at different corners of the world, each a domain expert, they sit together and decide how to set their TMM staging for their chosen cancers. So it is a huge realm that we're talking about. All right, nobody can say that he knows all the cancers at the tip of his fingernails. Okay, so this is just bladder cancer. All right. If there are no questions, then I will move on to upper tract urothelial carcinoma, which in itself also not easy. So that's why I want to ask you, bladder cancer. Anybody got anything? No? Don't be shy.
Yeah, actually, I was about to ask that, and you already answered. It looks like we need to develop a separate model for bladder cancer, right?
Yes.
It need to be treated separately. Yeah.
You can imagine why I didn't throw this topic right out at the front. Because it would have been very confusing. I know it's very confusing, but it's even more confusing if you guys didn't know anything about cancer. The first lecture was a precursor to episode 2. If without doing episode 1, y'all will know episode 2. If I throw your episode 2 right at the start of day 0, or day 1, when we start the project, it's even worse. So unfortunately, it's something that I had to do in progression. And this is how we also teach medical students too. Because there are always exceptions to medicine. And this is one in our field of urology cancer. Okay, so yes, Prof, I did what I did because I have a bit more experience with teaching medical students. That's how we teach, because we figure out over years and years of try and error. If you try to teach it in the other way, it's even harder to understand. Okay, so any other points anybody wants to make? Yes, we may have to think about another approach, and knowing that we can do this, let's just do this. Knowing that we know now a bit more about bladder cancer, we may need to get a bit creative about how we handle such things, right? Now, if nobody else has any other issue, we will go up to UTUC. Okay, so UTUC, I think Hong Hong is really laughing at the time I say this topic, because it's not easy to talk about it. And I still struggle to find a best way to teach people and to explain to them. And even I myself takes some time to figure it out.
You did a wonderful job.
Don't say so early first, because we haven't finished. So the best U in the U stands for urothelia. Urothelia means the kind of the cell type that lines the urinary system. I suppose urothelia is probably come from the word urine somewhere. I don't know that, but I'm bullshitting and I'm probably right. Urothelia is the kind of a cell that basically lines the urine. Urine is a very toxic thing. Its excretion is a waste that my body don't want. In my other day job, my interest is actually looking at this kind of a plastic structure called a DJ stand. A DJ stand basically is a stand that allows a block system, like for example, there's any reason why your kidney, the urine cannot go down from the kidney to the bladder. A stand like this come out with little hole so as to make the urine allows you to come through. And as a result, I study very closely about how urothelium behaves. Okay, urothelium lines the entire kidney all the way to the bladder and all the way to the urethra, to the place where the urine comes out. Okay, and bladder cancer that I just discussed just now is one type of urothelial cancer, because it goes on the urothelium. They are more or less the same. They are like cousins. All right, but if I were to stretch your imagination a bit, all right, what happens if I tell you that cancers can also grow here? Cancers can also grow here. Cancers can also grow here. I alluded to just now the instruments I have are so small. That's number point one. The other point I alluded just now is how to get an R0 resection. How do we achieve these two principles? This, by the way, is only 3 to 4 mm. That's the kind of fine work that I do. The width is 3 to 4 mm. If you were to use your fingernail, it's probably 1/3 the size of a grain, foot longitude, or the width of a grain. Okay, or maybe more, 1.5 size of a grain. How do you then, if you have cancer out there, how do you do a R0 resection? I cannot make a hole here because it's so thin. The cell here and the layers here is less than 1 to 2 mm thick. So if I may, essentially is a tube structure with some layers. Again, there are different layers that we decide the depth invasion. The unique thing about the ureter compared to the bladder is there is no thick muscle layer. So a urothelial cancer that grows up here very quickly hit the entire structure. And if you were to recall, we talked about this just now, TZTA is superficial. Once you hit muscle and beyond, go up to the fat is T3, T4. So if you get a urothelial cancer, you either get a TA superficial or you straight go up to T3, T4. There's no T2 because we cannot get a T2. There's no muscle, how do we get? So you jump. Very quickly, you jump for UTUC to a bigger depth. That's why UTUC is a different kind of a monster, I always say. It may be a urothelial carcinoma, but because of the way and the location that it is, it actually is a bit more dangerous. It progresses faster, it's harder to reach, it's even harder to diagnose. How do I say that? To diagnose, this little thing needs to wiggle all the way up to the lesion. And as you can see just now, the big fat nice video that I got, that was a bladder, very big space. But you can imagine if I were to talk about here, the space is a lot smaller. All right. The camera view I have is wow, like that. This is the lumen. And guess what? It starts bleeding. It's all red. And I tell you, blood and vision is no good. Everything is red. Everything is red, plus the cancer itself is red. You can imagine I cannot see anything at all. So it's not easy to diagnose. Yet it is a disease that can jump very quickly, which is why UTUC is a different monster. Even though it's actually in essence the same kind of the cancer that you see in the bladder, but bladder A got a lot of ways I can cut off and come back and cut off and come back. Why is the difference? And the difference easy is simply because bladder easy to survey, check, come back. The UTUC cannot. It's not something that I can do. This kind, I cannot do that like that. So I also cannot, because of my physical technological limitation, find an instrument, come here and then cut it like that. Because imagine, I said to you, this is 3 to 4 mm. By the time I reach this one, the instruments that I use here is usually 350 microns. And if I have a 3 mm cancer, which continuously bleed, which I cannot see properly, I cannot cut, which is why cutting UTUC, the traditional way of a TURBT, not possible. Not possible. By the way, TURBT is the one that you saw just now in the scope. I tried to cut off the bladder. I should have told you. Sorry. UTUC, you cannot be approached like that. And that's why UTUC, you finally, UTUC, you might see the standard 3 by 2 mm by 1 mm lesion. And usually there's only one reading. Don't have that, like the bladder, that number 2, number 3, or multiple pieces. Why? Because we figure out the best way to treat UTUC is actually, once you have something here, we don't take out this part. Once you have something here, we don't take out this part. We are very radical because it is something that I cannot grab a hold on. It's like leaving a time bomb in your body. What we do a procedure called a radical nephrouretrectomy. I take away kidney, I take away ureter, I even take away a chunk of the bladder. So in the specimen that you will get in the lab is like that, like that, like that, with the ureter and a big piece of the bladder. This is B, this is U, this is kidney, this is cancer. For a little dot like this, we take out the entire thing. Why? Because our logic explains our logic. Some people have really tried to take this off. Some people did try to take this off. And guess what? They see. Guess what? They find that 3 months later, they come and they go here. Come and later go here. Come and later go here. It goes everywhere. Why? Because I said to you, the urothelium is the same kind of a cell, right? If you can have cancer on that one part of cell, right? There's a neighbor. It can crawl towards the other side and then dump it down there. Because we got urine. Urine washes all the cancer cell down the lower tract. You can have it anywhere inside the system. Anywhere you can have seeding. So we learn through experience that the best way is to get rid of all the blue color, at least on one side. Again, I don't do it. I don't do both sides at the same time because I need some kidney function. If I keep at least the red color, he can have a fairly decent life. That's why I don't take out one. If I can, usually we'll strip everything away, but we cannot. That's why we end up doing a single specimen like that. But we talk about single specimen like that, right? Then they will tell you, doctor, your specimen is here. So you might have a lot of wording that talk a lot of things, but they will tell you lesion is 1 cm or 7 mm by 5 mm by 2 mm lesion for UTUC. All right, so UTUC in a way, it kind of go back to where the rest of the cancers are. You have one single dimension or two single dimension, because like I said to you, you can have one here and you can have one here, but it's because the way it's resected is an R knot, meaning I take everything out, right? I get the whole complete thing. We still try to do an R knot resection. We are not dicing and chopping, like doing mincemeat for bladder cancer to take it out. That is the essential difference why the same cancer is treated differently simply because it's at different location. At this point, I'm going to stop. Question, or am I confusing the whole world now?
Hi, Dr. J.
Yep.
So my question is for the dimensions that you mentioned, right?
Yes.
Does this apply to clinical staging or pathological staging?
Yeah. Sorry, what did you say? You need to rephrase the question again.
Yeah, your dimensions, the ones that you mentioned on the bottom
For
right.
bladder or for UTUC?
UTUC.
UTUC.
So is it for pathological or clinical staging?
Okay, good. So when we talk about histology, anything that comes out of the body already, I will introduce this term that you all might see. It's a T1, T2, T3. Sometimes you all will see this word. Sometimes you all will see this word. Okay? C means clinical staging. What do I mean by clinical staging? Clinical staging is when you will see this very commonly in the radiology report. Let me rewrite this. You will see this in radiology report, more so in radiology report. Okay. You will see this more so in pathology report. That's very simple. P, let's go with the simple one. P stands for pathology, meaning come out of the body already. Sure one. I'm very, very concerned. I'm very, very sure. Why? Because the specimen is outside in front of my table in a nice green cloth already. That's why we call P staging versus a C staging, C staging. C staging stands for clinical staging. Most commonly seen in the context that you have is radiology. If you think about it, it's actually quite common sense. Radiology is before the cancer is taken out, right? We have not chopped it out, right? We can only see and derive a clinical staging based on best available evidence, either picture, either what I see in the scope picture, and even if I see in the scope picture, I told you already, everything is so fuzzy and you can't see that. C is clinical staging. Clinical staging means I think it is T1, but we will always defer to P staging at the end of the operation. When the specimen is out, we get the PT1 stage. So if in anything else, PT staging will always trump C staging. The C and the P staging can be the same, but it is not uncommon to have the P that differs from the C. Again, whether which one is more trumps which one in the order of things, that is more of a Hong Kong shop. But now that you ask this question, this is something that you all will see. A small p or a small c. That is what the P and the C stands for. Pathological versus clinical. Clinical is best guess. But after operation, I chop out the whole thing. P is the ground truth. Does that answer your question? It was Desmond, right? I think it was Desmond asked this.
Yes.
Yeah. Does that answer your question?
Yes, it did. So yeah, just want to make clear that the one that you mentioned, the dimensions after taking out is pathological. Because there's on the form itself, there's pathological and clinical dimensions recorded.
Yes, sorry, it's not Desmond, it's Nazrul. Who was asking the question?
Yes, Nasrul.
Yeah, that's true. That's when you say yes. Yeah, so that's why you see a little small p and a little small c. The context, which is relevant because radiology report, which LinkedIn deals a lot with, we'll see the C likely. And if it's before operation is done, where the cancer is still inside the report, you can imagine it's almost certain the cancer haven't been taken out, so you can safely assume most of the time the radiology report will give you the C staging. For histology, which I think Fiona is dealing with, it's more likely to be if it's out already, it's definitely a P staging. It's a P staging, a pathological staging, and it's the ground truth. A pathologist basically cuts out the specimen, you chop it out into slices, thin slices, stain it with different colors, look under the microscope to give you the final ground truth. In the context of using the whole concept of ground truth, you can imagine this is what clinicians, the pathologist is kind of like the annotator for medicine. They are the final ground truth. No matter what I think was before the operation does not matter. What matters is what the end, the pathology tells me. Whether I've cut everything out, it's an R0 resection, it's an R1 resection. Not I say one, pathology has the final say. That's why they are always more accurate. So in the sense of a computing term, they are the ground truth. Other questions? No. So if not, then essentially we basically has hopefully nailed down a few one of those loose ends. Bladder cancer is one of them. We struggle sometimes. Now you understand. Maybe now you get a better idea. Sometimes me and Hong Hong just look at one of the problems that you raised up and go, okay, no need to talk because there's no point talking if I don't understand this lecture to you. Hopefully now that you understand bladder and urothelial cancers, you get a better idea of what we are dealing with. Okay, I would show you the video again just to get an idea. Now that hopefully after I've gone through bladder cancers, looking at this video of what are the challenges I feel, this is a very small instrument, huh? You can understand why I do things a certain way. Imagine the size of the scope. Imagine there's so many lesions. Imagine I cannot take out the whole big lump like that. They are bigger than my instrument already. That's why we had to do certain things for bladder cancers. By the way, for this gentleman, I decided there were too many cancers that I gave up. I only took one sample to have a histological report. So imagine that histology report, he will only have 2 or 3 dimensions because I only bite 1 or 2 bites. I stopped the bleeding and I got up. I took one that looked at the depth. I carved into the muscle layer that we talked about. I carved into the muscle layer. For this case, I look at this part. I took one chomp here. I sent off this piece, and I left all the rest of the cancers around because this patient has a bad prognosis. Bad story. Why bad story? Because he was in denial. He refused to believe that he had bladder cancer, even though he was peeing blood for 1 month. So, one of my guys chased and finally he came back. But let's just give you a bit of a background and the challenges that we deal with. All right. Apart from the reports that you have to grapple with, my dimension is getting the patient there is already a problem sometimes. All right, but that's not within the scope of the project. Okay. I don't want to start another topic today. In fact, I want to hear what are the challenges that Fiona and LinkedIn have. Because I think it's more important to cater to your needs, not cater to my needs. So, what are the other topics or broad topics, Fiona and LinkedIn, that you all have that you all want me to handle? Or you don't understand more? For that matter, any of the team members, Nan or Eileen or Nazril, any specific oncological aspects that you all want me to tackle next? Hong Hong, any burning issues that you think I should address? Because bladder cancer, more or less, is probably the hardest.
I think so far waiting for NTU side to respond. Yeah, for natural question, I will follow up with a table. Yeah, about the pathological staging and the clinical staging.
Yeah, so Fiona and LinkedIn, really, this session is only useful when you guys, I answer questions that you guys require. I say again, feel free to write down and jot down the various challenges that you have. Because if you do understand, if you don't understand, there's really no point.
Hi, Dr. J, Eileen
Yes,
here. So maybe you want to maybe share a little bit on like multifocal cancers or how do we identify tumors? Would that be? Yeah.
Multifocal question. Another page already. Another page. So I like my iPad. I can do whatever I want. Yeah. Okay, multifocal cancers. There we go. Good question. So again, the usual picture of we have this 2 ball that we see. This 2 ball structure is a prostate, the bladder, the ureter, the kidney, the urethra. You will see me drawing this picture over and over and over and over again. Okay, so with regards to your question, probably relevant here. The bladder that we talked about just now, the prostate that we talked about just now. So when you have a P and the bladder, this is the bladder layer. Sometimes when you have a cancer here, it didn't come in early. Patients, for whatever reasons, come in only when the cancer has reached here. Remember, I drew this, everybody can clearly see that it's from the P go to the B. But when I go into the scope for the first time, I don't know whether this is like that or it's like that. Is it a bladder go to the prostate, or is it a prostate go to the bladder? So this is one aspect that you will continuously face because they are nearby neighbors. I don't know who started the fire. When I got there, both flats were already on fire. Of course, if the neighbors can tell, oh, it's unit 1 straight to unit 2, then great. But there is no neighbor or there is no innocent witness in the body. Nobody can tell you. How do we then tell? We chop everything out. This whole thing comes out. We put under the microscope. You all saw the picture just now, right? Bladder, usually they're kind of like corals. For those of you who dive, they actually look like hammer corals, a kind of a corals that looks like a hammerhead and floating in the water. And they really look like that. They float, very beautiful sometimes. They look like that. And some of these hints we can tell. For prostate, because I cut so much, I know that they are looking at different things. They look more solid, more meaty. If I can describe it, it's like custard, egg custard, the top layer with the egg. So one looks like a coral in the sea, the other look like custard. So of course, if I chop it out, if they look like that, I can hazard a guess, it's probably the prostate if it looks like custard, and it's probably, if I see custard inside the bladder, I say this is probably prostate cancer. If I see the fonts inside the prostate, I can see slightly the bladder stretches to the prostate. That's how we do detection. Of course, the histologists, then basically they are a lot more better than me, right? And they cannot be looking at food. But pathologists love to have food, by the way. They describe everything in food. So what they do is they slice, stain it using the various stains that they always traditionally use to work, and then put it under a microscope to look at some stains. Some stains for prostate very well, some stains for bladder very well. That is another reason why you see a lot of things like Ki67, the chromophobic stains, and the don't know what stains, and all these kind of controls are normal and abnormal. These funny numbers are actually different kinds of colors that they put inside to test and to confirm that it is a cancer of a specific type. For example, prostate stands for ABC, bladder stands for 1, 2, 3. Then they tried it with ABC and 1, 2, 3, and it respond to ABC. They know it's one way or the other. That's how they work. Okay, that's why the last paragraph of any histological reports are always like that. So that brings me to some of the questions that we face. Multifocal cancer. Cannot tell. Not because me and Ho Ho want to make life difficult from you. Sometimes when it's too advanced, no more custard, no more coral, you know, it becomes like marshmallow. I cannot tell. Cancers are cancers because they don't follow rules. At the start, they do follow some rules. But when they grow until a monster itself, they don't necessarily conform to anything that we want. Sometimes it's really very hard to tell whether this is a cancer that came from the prostate and the cancer at its advanced stage. I add another dimension of difficulty. If it's actually a spread, meaning to say, it didn't look like custard, it didn't look like coral, it looked like, I don't know, give me a food. It looks like mashed potato. mashed potato doesn't normally exist in the prostate and the bladder, then where did the mashed potato come from? As much as you would like to think, we cannot tell where all the mashed potato came from. If it's a mashed potato that's not traditionally found at this location, we have no idea. Sometimes the source, we go unknown source. Then after operation, we come back, we see histology report. We end up rescanning the patient left and right, trying to find hint, marshmallow or mashed potato, or is it just mashed something? We try to then search for the common suspect, the usual suspect, to look for a source. So sometimes when we think that it's prostate cancer, when we think that bladder cancer, we come out already, it's totally out of our expectation. We then go back and do more scans to try and figure it out. These, you will see that in the context of histology, unknown primary, or unknown this, unknown that. By the way, doctors, being doctors, they're damn smart. They will never admit that they are stupid. So they will never say, I don't know. You will never see the word I don't know. Instead, you will see words like unknown, indeterminate, suspicious, suggest. That's the pathology. Radiologist, my brother is one radiologist. He will always put in down there one big word at the line of every paragraph. Clinical correlation is suggested. It's a nice way of saying, I don't know. Go and figure it out yourself. Because they will say, I never see patient, you see patient. But they think that I can put the finger inside the prostate and then feel the prostate and then figure out where the prostate cancer is from. But that's what they do anyways. They say clinical correlation. Go and find signs and clues in the patient, look at it, figure out that, then you get a better guess. That's how they work. So there are many, many, many unknowns even in the histological report, even if it's supposed to be a straightforward diagnostic histological report. Okay, so multifocal, okay, multifocal, I extend a bit more, multifocal and even a bit of unknown primary source. Because that I want to link into the third one that you probably, you didn't know where you're coming from. The context that you're probably talking to me is, the source is not so simple like what I drew here. It's probably more like the liver, or something like that. Then the liver got that kind of cancer. Suddenly this cancer appear here. This is multi-source, far away source. Things that you will never encounter one. We say urology is actually this, strictly speaking. But many times we get our surprises here. The multifocal, it actually can come from even the lungs, the abdomen, the liver, and even pancreas, or even spleen. On the other side, it can come from any of these sources. When we talk of this thing, we thought that it's going to be a prostate cancer. It didn't. It's not much. It's not custard. It's not coral. It turned out to be gado. We have no way of controlling. So does that answer your question, Eileen?
It does a bit, yeah. So because you may have difficulty understanding, there may be one tumor within the report, for example.
Yeah, so there'll be more. It's exactly, you're right. Okay, wait. There's one thing I wanted to tell you. So let add another dimension. Okay, add another dimension. Now we're looking at side view. Side view. The bladder comes like that. The prostate, the urethra in the male, the kidney comes from here. This is the bladder. Okay. A more common thing that I forgot to mention is the rectum. Okay, this is the rectum. I'm sorry, the rectum comes out. Very commonly, cancers from the rectum, green color, invade here, or invade the whole space here, and then eat into here. Very, very common. We are good friends with colorectal surgeon because they are so close neighborly organs. The prostate can affect the rectum. We can go that way, or it can go this way. Although more happens here than the other way round. Sometimes we can see. So essentially, the histological subtype of colorectal cancers is adenocarcinoma. Also adenocarcinoma, carcinoma type. You know prostate got adenocarcinoma, right? You also got colorectal type 1. So colorectal adenocarcinoma is different from prostate adenocarcinoma. How do they differentiate? I mentioned this stains, different stain. All right. So that's why sometimes when you do exenteration is whereby I take off this part. I take off this part, and I take out this part, and I take out this part. Everything take out. So immediately, the patient comes out of operation with 2 stoma, 1 for stools, 1 for urine. No more, no function below. Ladies, even worse. We take out your womb, your uterus, and on top of the bladder and the rectum. It's called exenteration. Big surgery, usually around 9-10 hours. So that's how it can get complex. And I would imagine this is the context that you may encounter. Again, Elaine, I would like to know more. If it doesn't answer your question, feel free to remodify your questions. Maybe I'm not understanding it well.
Okay for now, yeah.
Okay.
Whether they got any other question?
Don't feel shy. Don't feel shy. Fiona, Ling, you are my concern. I'm very worried because Elaine, all have access to me. Hey, Elaine, your office are still at One Connection or you all moved already?
The same connection one.
Still not coming to OCH?
I didn't hear anything about it.
Oh, yeah, still so far away. Okay, anyways, yeah. Fiona, Ling, any questions? Yes, Fiona?
Don't have. You explained it very clearly.
Okay. It's clear now because after that I say already, then after that you will forget when the moment you get up. But feel free to jot down any more new things. Okay, I don't want to drag any longer. I want to keep
Dr. J.
Yes.
During the previous meeting, you mentioned that you wanted to talk about TCC and RCC. Is that?
Hello, TCC lo.
Also UTUC.
Okay. So okay, TCC this schematic TCC stands for transitional cell. Then they basically change become urothelial. So TCC is kind of an old name for bladder and TCC upper tract. So now the new one becomes bladder cancer. The subtype of which is TCC, and UTUC. So I'm giving you the updated one. We kind of veer away already to these two kind of reporting. But why is it important again to you is a good question, because depending on the period of which you read the reports, if it's 10 years ago, they still might use TCC of the upper tract. Now they decided to clearly call UTUC. Hong, can you illuminate a bit? Does the histopathologists, are they good boys? Do they use the right terms or do they anyhow use?
Usually for TCC cases, they use urothelial carcinoma. They use term like this. Yeah, this is a histology type.
TCC kind of like an olden historical naming, right?
Yes, but in some report they still use TCC this term.
Yes. So know that TCC UTUC is interchangeable. The way to look at it is where it is actually located. In the bladder, you traditionally call it bladder cancer. The subtype, the cell type is TCC. Usually TCC nowadays they use with bladder cancer. On the upper tract, they are supposed to change to UTUC, but as we know, habits die hard, so some people don't actually change the way they're supposed to change. Any other question? Hey, actually the SRP should come and listen to this. Okay. Sorry, one of my students suppose actually I thought might be useful. Okay.
Dr. J,
Yep.
I'm looking at Kager stage, and so is there any like obvious rules or anything when we look at the report, we can determine the stage for that.
Can you rephrase your question? You are looking at what, sorry?
Clinical stage N.
Yes, yes,
Not,
clinical staging.
yeah.
Yes. How about it? So what do you want to find?
I have no idea when look at the report to try to decide which stage is that. Now, is there any very obvious?
Okay.
Yeah.
Very simple. Ling Ting. Can see that? Can see, right? Can see, yeah?
Yeah.
You just go TMN and no. TMN and you search for whatever organ you want. Prostate. Go. Almost immediately go straight to the images. Don't bother. And then you can see any one of this prostate cancer. T staging. This one comes with a T staging, the M staging, and even the M staging. Okay? Not what you want. Change. Renal cancer. Oops, sorry, spell wrongly. Same thing. Every cancer got their own staging. So Ling Ting, this is no rules, but a trick for you to do. Now, why are they so new? Because you see, for example, this one, T staging is T1. Sorry, it's a bit blur. You can see, right? T1 is still sometimes they go by size, as you can tell. T1, T2, this size, that size. T2B one size, okay? But for certain other forms of cancer, prostate, for example, size is irrelevant. They go like, where is it located? This one, they look at lobe. Whether it's stick into the lobe, stick into the confined to the prostate, confined to the prostate, not confined to the prostate, went outside the prostate. T3A, for example, is called extra capsule. Prostate is surrounded by a capsule. They call it go outside the cancer, go outside the prostate, they call it T3. So some goes by size, some don't. Let's go and talk about the bladder cancer we talked about today. Bladder cancer don't go by size, and I'll explain to you why. They go by depth of invasion. Superficial is called TA. Then there's T1. T2, T3 is how bad. T2, as you can see, once you hit T2, that layer is the muscle layer. T1 is the laminar propria layer. TA is the superficial layer. The more superficial is, I don't care. You won't die one. You come back and just keep cutting. The muscle, T2, is bad news. And running you hit T2 or T3 or T4, equally bad news. Now let's look at, so you see bladder cancer don't look at size. Prostate cancer don't look at size. Renal cancer looks at size. UTUC, we talked about this just now. UTUC, UTUC, I told you, right, the size is not a good way because the size is so thin. You can't tell. Oh, here we go. This is a nice schematic about the UTUC. But if you think about it, these are all very heavily magnified. The ureter, I tell you, the overall is 3, 4, 5 mm in thickness. The whole thing is the thickness. And then the layer of that tube alone is, if we're talking about microns, then even if you microns, you magnify, at some point in time, you cannot tell. Let me give you an idea of what you are dealing with when we talk about histological report. To be fair to our colleagues, this is what they look at. You can see in this case, very nice snaky layer. That is the clear definition of one layer from another. Not everything is in tube structure lifestyles like I draw. Bladder is not like that one. They are dealing with this. You can see clear layers differentiating from one layer. You can see the smooth muscle. You can see the musculary. You can see the stratified epithelium, the squamous epithelium. This one, you can even see a T-rex. But when you talk about cancer, they are very, very, very advanced. You go like this. I cannot tell any structures. I can't tell any stain. Although I said to you, stains generally a few stains can come together to give you an idea where the organs come from. There is really no one specific stain that stains only and only for prostate tissue. Neither is there one stain that stains only and only for kidney cancers. Usually it's a combination of 2 or 3 stains because each stain stains 2 or 3 or 4 or 5 parts of the body. And sometimes when some stain pick up, some stain don't pick up, they scratch their head. All right, and they cannot tell you why are certain things like that. You understand? So to be fair to them, not everything is like this colorful with very, very nice borders. Not everything is like this, very, very nice pictures that you can see. They can be dealing with this. To the untrained eye, they look like tadpoles to me, man. More like dragon fruit that I ate last night. But to them, they can figure out what cell type is this. And sometimes it takes a lot of interpretation to tell you what they think. Got invasion or not? Some invasion. Certain areas got invasion. And remember, this is one slide, one field. They must scroll through the entire field, of which all looks like this, and to try to look for subtle signs to tell you whether they invaded or not. This is the kind of challenge our colleagues at the histopathology face. All right, LinkedIn, does that answer your TMM staging question? Simple. Go to the internet, TMM, type that one. There's TMM for every cancer: penile cancer, testicular cancer, prostate cancer, bladder cancer, urothelial cancer, kidney cancer. All have. Histology, I told you a bit about what they do. Very, very difficult to do things all the time. It really not easy. I don't want to take it away from them. As much as I would like them to report things, yes, no, maybe comes out very often compared to what you guys think. And I show you why. Histologically, it's not simple. All right, so label. Let's go at the label one. Not everybody is like this one. Very, 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 very poorly. Let's look at undifferentiated. This is called undifferentiated. Undifferentiated cancer is another way, basically the way of saying very, very aggressive cancer. They invade everywhere already until I cannot see any structures. This is the kind of film that you can be chased with. Do you see? If I tell you this is used to be a prostate that used to have the nice little curve that you see down there, but after that being invaded by cancer looks like this. Can you tell me where is where? I cannot. You see? You don't see any structure anymore. Everything becomes a hue of red, purple, more red, more blue, something like that. Yeah? Ken?
Yeah, thanks, Dr. G.
Dr. J, I got a question.
Oh, yes.
So for like pathology reports, right? They can use different terms to like sort of define tumor, but they are usually not clear. So like sometimes are like lesion, tumoral nodules, focus.
Yes, but that's radiology, right? You're talking about now.
No, pathology report.
Oh, pathology. Okay, Ken. What about it?
So how do I determine if these are referring to tumor? Because dimension can appear like with these terms.
Yes. Remember, I went back to the point that I told you about hedging and hedging. Hedging means just putting. You understand the concept of hedging. Hedging is just basically putting up a potential disclaimer. So when certain things are too small to report or to be very clear, because either due to the fact that they really don't know what it is, or because it's really too small to tell you. Remember, scans the resolution is not that sharp one. Let's look at scans. Scans. CT scan. Now this is a medical image of a scan. Everything is black and white. From the black and white, they tell you many different things. For example, this one is black and white. It takes years and years and years of training to tell me that the top left-hand corner here, this is the liver. Below it is the bowel. This is the spine. And then this is the uterus and whatnot. Years and years and years of training. You cannot tell one. as much as I like to tell you, people can tell you that little dot here in the middle is a cancer for sure, 100% chop stand guarantee. They cannot tell you that because they do not know. So that's why they always say lesion. They hash. They say lesion. I saw something. I don't know what is it. And I told you, right? Go back to rule number 1. They will never admit they're stupid, right? So they will say there is something down there. I don't know what is it, but there's something down there. So, understand?
Yeah.
Cannot blame them lah. But they will say lesion, no. I do that. The answer. So you always remember. Sorry, this is another concept that I like to use. Not knowing or I don't know is also an acceptable answer. So if they have a lesion 1 by 1 by 1 by 3 cm of I don't know, it's also an answer. You understand?
Yeah.
Not knowing is also an acceptable answer. You do not have to find an explanation. I do not expect algorithm to give me an answer for every single little thing. Sometimes I don't know is also an answer. If it's truly, I don't know.
Okay.
Prof, anything?
Yeah, I think the thing is getting clearer, and also we know the thing is getting more complicated.
Yes, the more you know, the more.
Yeah, so in the sense
it's
that
like me knowing a tokenization.
Why? Because like this clinical the different stages, right? For different cancer, they have different criteria, like the T1, T2,
Yes,
right?
yes.
Then unless there are very clear rules that from the report we can derive, or the stages like T1, T2 is clearly literally written in the report. Yes. Otherwise, it's going to be very difficult to predict the number.
Yes. So you understand, Prof, there are two things that we're trying to do here. When we say predict report, initially when I first started the project, I actually wanted you guys to read the dimensions and then use the dimensions to put it into the well-known or the latest TMN staging for, say, a cancer, which is less than 4 cm, and we can rule-base that. That one is very simple to rule-base. But I don't think we are there yet.
No, even the dimension extraction itself is difficult.
Correct. So the dimension extraction is itself an issue. And only when you can give me accurate dimension, I guarantee you my next challenge to you is to put it into this rule base, which is actually the simpler thing. It's not that hard because AJCC has updated one. There is in fact a rule for your rule-based approach. It's just in the thick book.
Yeah, I have that book. Yes.
Yeah, that book is painful. Oh, why do you have that book?
No, I have. I sent Hong sent this to us. Yeah.
That book is painful.
Yeah, but anyway, I see the challenge here is that for extracting the dimension itself, I think Fiona is working on that. We're trying the different models.
Yes.
But because the way of the expression, right? I mean, sometimes they can mention very clearly. Sometimes they try to use a kind of different terms. And also the dimension may appear in different contexts. So we are still working on that. So the results I wouldn't say is very high. That is reliable to like apply the rules to determine the different stages.
But I understand. I think me and Hong Hong get it. We understand. We understand the challenges you all face. We do not downplay it. And it, like I said, it took me 2 or 3. Imagine if I giving you 2 or 3 lectures in a very process where the way you explained to me tokenization yesterday, 2 days ago. Can you imagine if I go and read the tokenization myself from page 1 all the way without a process thoughts? And for medical, it's the same thing. I hope that with all these little short sections, we get better and better and better. You get more and more challenging questions, and I gauge an understanding of your appreciation of my field by the questions you ask. Similarly, I believe you also know whether I'm dreaming or not by the questions I ask you during your lecture. So it's the same thing. We ask, so the questions will come. And I'm glad everybody's asking questions because you're not going to get this lecture anyway. I think you're not going to get it. Yeah, so pretty much this is the only forum, and I don't know how long I can do this. I'll do this as long as I can for this project. But if let's say tomorrow another project comes up, I don't want to start with another new group of people. That's why I say when you get the foot into medical AI and / annotation, you understand they're not going to get the help that you, or rather the support that you have already. So use me, ask question, be a leech, don't be shy.
Yeah, I understand. I mean, basically, we're trying to see the challenges we're facing. So, I think from both sides, we need to have more realistic kind of expectation from the final results, all right? Well, so I can also share